Hey friends, welcome back to Med School Moose. In this video, we are going to be discussing the chief complaint of shortness of breath and everything that you need to know to be successful on your emergency medicine away rotation or sub-I. Hopefully you've had a chance to watch part one of this series that was about chest pain. If you haven't, I'll be sure to link it right here. Definitely check it out. I think it's really important. We're going to keep going on with the series. As always, this is not professional medical advice. This is just for educational purposes only. And this is primarily meant for fourth-year medical students going into emergency medicine, doing an away rotation or a sub-I. That being said, this information is also super high yield for emergency medicine interns, third-year medical students that are doing emergency medicine, as well as anyone else that is interested or works in emergency medicine. All that being said, let's jump into it. So same outline as last time, and this is the same outline that I'm going to keep as we go through these chief complaints and break them down. We're going to start highest yield differential diagnosis, the can't miss diagnoses, some of the lower acuity things that we should be on the lookout for, and of course throw in a couple zebras to round out your differential diagnosis to make you look good on your away rotations. We're going to talk about some of the critical questions that you need to be asking when you're interviewing patients with this chief complaint, some of the physical exam skills that I think are important, what we're going to do for the workup, and then some final pearls to make sure you know everything that you have to nail this differential diagnosis when you're seeing it in the department. So let's start right at the top with the differential diagnosis, and we're going to start with the can't miss diagnoses. And hopefully, if you've watched the first video, a lot of these look familiar to you. Chest pain and shortness of breath in terms of chief complaint and the differential and the workup. A lot of these things go hand in hand. We're worried about a lot of these same things. So the can't miss differential diagnosis when it comes to shortness of breath, we're going to start with myocardial infarction. Of course, that is something that we need to be on the lookout for. Shortness of breath is something like an anginal equivalent for me. These patients still need workup for an MI. Pulmonary embolism, of course, cardiac tamponade. So a large pericardial effusion can absolutely cause shortness of breath. Pneumothorax, which we discussed previously, pneumonia, and then two other can't miss diagnoses when it comes to shortness of breath are anaphylaxis and angioedema, which is why it's so important to do a good history and a physical exam, see if there's any signs of any recent allergic exposures, see if there's any signs of any oropharyngeal swelling, because you cannot miss these things because it can turn into an absolute airway nightmare. In terms of the lower acuity differential diagnoses for shortness of breath, congestive heart failure and chronic obstructive pulmonary disease, COPD, are still there at the top. I know certainly patients can come in very sick with a CHF exacerbation, with a COPD exacerbation, but we're going to keep these on the lower acuity part of the differential diagnosis for right now. Same thing with asthma, and asthma exacerbation can be mild, moderate, or severe. We're going to keep it on lower acuity as well. Anemia is an important one to know. Patients who have symptomatic anemia, we're talking hemoglobin of 7, 6, 5, maybe even lower than that, can certainly have shortness of breath. So we need to be on the lookout for that. And then some other things like pulmonary contusion, especially in the setting of recent trauma. If a patient comes in after a car accident and they're having some shortness of breath, some dyspnea, we want to be thinking about that. And common things being common, we want to keep viral respiratory infections on the differential. Of course, nowadays, COVID-19 is still going around. I'm still seeing some sparse cases of influenza in the hospital, even though it's the summer. And then, of course, in the winter months, other viral respiratory infections like RSV are wildly common. So you want to be on the lookout for those as well. Rounding out the differential diagnosis, we want to know some of the zebras when it comes to shortness of breath. Top of that list is going to be pulmonary hypertension. Probably not something that we're going to diagnose in the emergency department, but if we have suspicion of it, if we see signs of it on imaging that we do, that might be a patient that needs admission because these patients can get very sick very quickly. Hemothorax is another zebra, especially with traumatic finding. We want to be evaluating for that. Neuromuscular disease, things like myasthenia gravis, Guillain-Barré syndrome, not very common, but I have diagnosed it from the emergency department before, so you want to be on the lookout for that. And I wanted to add this last one, these occupational lung diseases, to the zebras as well. These are things like asbestosis, silicosis. For a while, these occupational lung diseases really seemed like random zebras to me, but recently in the emergency department, I had a patient that sounded like a classic board's question for silicosis. It was a patient who was working in construction. He told me that his job was working out in the desert where they were blasting rocks, and it was his job to basically spray that dust down so that it doesn't aerosolize very much. He had been doing this for a while. He wasn't wearing a mask. His mask had broken, and he came in with shortness of breath. So it seems silly, it seems like a zebra, but this is something that I saw recently, so I want to make sure that you're aware of it and keep it on your differential diagnosis for shortness of breath. Moving on to the critical questions now, of course, we want to ask all of our old carts questions, but these are some of the other important things that we want to be thinking about. Have there been any recent exposures, whether that's to smoking or allergens or from the occupation like we just talked about? Is this shortness of breath, is it worse with exertion and better with rest? Certainly if a patient has dyspnea on exertion, we're more concerned about something like a pulmonary embolism. is the shortness of breath worse with lying flat, orthopnea? If the patient is telling us that, they're saying that they used to be able to lie flat when they were sleeping, now they need to prop themselves up with a few pillows because of that orthopnea, then maybe we're going more down the CHF route, whether that's new onset CHF or a CHF exacerbation. How far can the patient walk? This is something that I love to ask because it really kind of gives me a better understanding of what the patient's dealing with. When I'm interviewing a patient with shortness of breath, I ask them, do you think you could walk to that counter over there that's 5 feet away or 10 feet away? And if they say, no, absolutely not, I'm going to get short of breath, that's a really good idea for me of how dyspneic this person is, even with simple activities. And to go along with that, is this shortness of breath interfering with their daily activities? Are they unable to get up out of bed without feeling short of breath? Are they unable to make it to the bathroom without feeling short of breath? Are they unable to get to the kitchen to make food for themselves without feeling short of breath? Interference with these daily activities is not only important for making the diagnosis, but also the prognosis, whether this patient needs to be admitted or if they can go home. A couple quick points for physical exam when it comes to shortness of breath. Definitely be sure to auscultate breath sounds. It seems obvious, but a lot of people nowadays, they're not doing it. They're not walking around with the stethoscope. There's a running joke in the emergency department that the stethoscope is kind of just like a nice thing to wear around your neck. But really, in something like shortness of breath, auscultating breath sounds can give you a lot of information. So definitely be sure to do it. Another physical exam tip is you want to observe the patient's work of breathing. And sometimes, honestly, I'll just lift the patient's shirt up and kind of sit back and kind of watch them breathe for a minute just to get a good understanding. Are they exhibiting things like pursed-lipped breathing, which we might see in COPD? Is there accessory muscle use? Are they using their intercostal muscles? If it's a pediatric patient, are they doing tracheal tugging? Is there tripoding? That's suggestive of impending respiratory failure. Even observing that for just a few seconds can really give you a good idea of how severe it is for this patient to be breathing. And then, of course, doing a bedside ultrasound if you're able to, if you know how to do it, if you can do it with the resident or with the attending. This is super helpful to identify things like a pneumothorax. If there's any signs of a pleural effusion, you can sometimes even see signs of pneumonia on ultrasound. So this is a very powerful physical exam maneuver, is that bedside point of care ultrasound. Another thing I want to mention, if you're the medical student that's examining this patient and they're hooked up to the monitor and you see their oxygen saturations dropping low, 89, 88, 87, go ahead and feel comfortable throwing them on nasal cannula, even just for the short term. If I'm working with a medical student and they're presenting this patient and they tell me, hey, the patient was 85% on room air, so I threw them on 4 liters nasal cannula and that improved their oxygen saturations, you look like a rock star. Not only did you go in there and get good information, but you also started an intervention to manage the patient to improve their oxygenation status. And even if we need to take it off later or move them to something else, you at least started the treatment, which makes you look good. Now let's move on to the workup. The workup's going to be pretty similar to chest pain, like I said, right? A lot of these things when it comes to chest pain and shortness of breath, we're evaluating for the same things. So of course, getting an EKG to make sure there's no signs of ischemia or a STEMI or an occlusive myocardial infarction, as I like to say. Getting a quick chest x-ray that can show us if there's any signs of a pneumothorax, a pneumonia, a large pleural effusion, a large hemothorax that could be causing this. Of course, getting that troponin in the appropriate clinical setting if we're concerned about a pulmonary embolism, screening with a D-dimer to see if we need to do additional testing, like a CTA of the chest. Getting a respiratory swab, sometimes it'll change management if there's some medications we can give to the patient, sometimes it won't, but it's also additional information to know if that's something that's causing the patient's shortness of breath. And then one other thing that you want to throw on there is an arterial blood gas. If you have a patient that is really short of breath, really hypoxic, getting an ABG can be really helpful in identifying what the cause of that is, what their oxygenation status is, if they're becoming hypercapnic, that kind of thing, to see if we need to take more advanced airway measures. And then some important pearls when it comes to shortness of breath. One thing that I like to talk to medical students about is distinguishing between an oxygenation problem versus a ventilation problem. If a patient comes in and they're short of breath and their oxygen stats are in the 70s, that's an oxygenation problem, right? They're not getting enough oxygen, so we need to do something about that, whether it's nasal cannula or a non-rebreather or non-invasive positive pressure ventilation with a BiPAP or a CPAP. That low oxygen number is an oxygenation problem. If a patient comes in with COPD, for example, and their oxygen saturations are 92, 93%, where we want it to be, but they look terrible, they're dyspneic, right? They're having a hard time breathing. Well, that's a ventilation problem. That's something different. And that's a patient that definitely needs non-invasive positive pressure ventilation to kind of help with the ventilation problem that they're having. So being able to distinguish that is really important in figuring out how to manage these patients. And then kind of going along with that, thinking about your oxygenation plan for this patient. If their oxygen's just a little bit low, okay, sure, we can throw them on nasal cannula. But what do we do if they're not getting better? Do we switch to a non-rebreather? Do we consider something like high-flow nasal cannula? Do we think about a BiPAP or a CPAP? Or if it's really severe, do we need to move to endotracheal intubation? And as the medical student on a sub-I rotation, you might have the opportunity to do this intubation. So you want to be thinking about how you're going to do it, what medications you might use, how you need to position the patient to optimize them for an intubation. Of course, the resident and the attending will be in the room with you. They're going to set you up for success, but at least having a thought process about how to do this will make you look really good on your sub-I and will also help you nail that intubation if you do get the chance to do it. Another pearl is, of course, doing an ambulatory oxygen test. If you have a patient with shortness of breath and your workup is negative and they're looking okay, definitely want to get them out of the bed, ambulate them, see if their oxygen level drops. And if it drops low or they're really dyspneic, that might change management and that patient might need to be admitted. And another important pearl is being aware of what I call subclinical pneumonia, also known as occult pneumonia. Sometimes in really young or really old patients who don't have a very good immune system, they can't mount the same response to an infection, to a pneumonia, as normal healthy people can, right? They might not be able to develop a fever. They might not be able to develop tachycardia in response to an infection. And we might not be seeing signs of pneumonia on a chest x-ray yet, but especially in some of these COPD patients, they can have a subclinical or an occult pneumonia that just hasn't developed a focal consolidation yet. So in the right patient population, if that's something that I'm concerned about, I'll do some shared decision-making conversations with the patient as to whether or not we should start empiric antibiotic treatment for a subclinical pneumonia. Everyone's practice pattern is different. That's something that I feel comfortable doing, but definitely something that I want you to be aware of when you're taking care of these shortness of breath patients in the department. As always, thank you so much for watching. Be sure to subscribe to receive all of my latest videos. Click here on the left to watch my sub-I series on the chest pain chief complaint, and click here on the right to watch another video YouTube thinks you'll enjoy. Thanks for watching. I'll catch you in the next one.